So we have, oh, okay, let's see. Okay. So So we have this anatomical snuff box. And remember, at the base of this anatomical snuff box, basically we have that scaphoid bone, right? It's really important to remember, right? So most commonly fractured carpal bone is going to be your scaphoid bone. And how does it get injured or how does it get fractured via injury called as push injury? So what is push injury? It's fall on outstretched hand. If someone is having outstretched hand and he's falling, so it's going to damage this scaphoid bone that's going to be most commonly fractured, right? So it can also occur in avascular necrosis as well. For example, remember one thing: the blood supply here to this scaphoid bone is like like the blood first of all move forward and then it would just come backward, right? So this part of your scaphoid bone basically get its blood supply in reverse direction of movement of the blood. Normally the blood moves in this direction, right, to your hand, but these portions of scaphoid, it have like a kind of turn here, right, of the blood vessel. So that's why this portion, which is also known as the waist, right, the waist of scaphoid bone is most commonly, it's prone to get avascular necrosis if you have compromise of the blood vessels here, right? So it's going to damage this area. So you can have avascular necrosis as well. Okay, so you can see the scaphoid bone blood supply. So we have palmar and dorsal branches. The radial artery basically supplies it. So the radial artery supplies the distal bone, and the proximal bone relies on retrograde. So as I already told you, you have the proximal and the distal region, right? So here in the picture, I already just have indicated that this proximal portion is basically dependent on the retrograde flow. Does that make sense? So this proximal portion rely on the retrograde flow of the blood. Is it clear? Hello? Hello? Okay.
Yes.
So the radial artery, okay, so or the distal is going to be supplied directly by the radial artery, then the blood supply have to take a turn in order to supply the proximal branches of this bone, right? So avascular necrosis, loss of blood supply. If the blood supply is lost, we know that the waist of your scaphoid bone is prone to get avascular necrosis. So this is basically the waist of your scaphoid bone, right? And a non-union, right? So failure of the bone to heal, as we know that the blood supply is retrograde. So and whenever we have any problem related with disruption of the blood supply, it would be very difficult for the bone to get fused again, right? Because fusion of the bone again need a lot of blood vessels as well, a lot of nutrients in order to have proper growth of bone. Okay, lunate dislocation, really high yield, really high yield. You're going to have a lot of MCQs based on this lunate dislocation as well, right? An important thing which you have to keep in mind that this is your lunate bone. We know that, right? Lunate bone basically sit here, you know, just above your radius. Am I right? Hello? Hello?
Yes, yes, sir.
Hi, yes.
Whenever an individual just fall on outstretched hand as well, what would happen? All of the bones are going to move backward, except your lunate bone as it is sitting on the surface, almost on the surface of your radius. So it's going to move forward. Does it make sense? Most of the bones are going to move backward whenever someone just fall on an outstretched hand, except that of lunate, which is going to move forward, right? And as it moves forward in this way, it's going to compress the median nerve. That's really important, right? So it's going to compress the median nerve. That's really important, okay? So how does the lunate dislocation occurs? We discussed fall, if someone is having fall or any trauma to the bone, lunate attached to the radius, we know that other bones are going to be forced backward, but since it's directly sitting on the radius, so it's going to move forward or backward, which is going to compress which nerve? Your
Yeah, no.
median nerve. Is it clear? So it's going to be your UWorld MCQ lunate dislocation is going to cause damage to the median nerve. And if you remember carpal tunnel syndrome, do you guys remember carpal tunnel syndrome? So we have a band of a fibrous band which is known as flexor retinaculum, right? So this fibrous band beneath this fibrous band, like most of the tendons of the muscles are going to pass, and along with that, your median nerve also passes. So whenever we have compression here, like we can see it in a lot of cases. If you remembered, I just told you. If someone remembered, I just told you I'll be discussing this again in MSK dialysis related amyloidosis. Remembered? I just told you once we were discussing MHC1, receptor, beta 2 microglobulin, remember?
Yes.
Hello?
Yes.
Yes.
Yes, what I
Yes.
told you,
Remembered. Yeah.
beta 2 is basically the structural component of your MHC class 1. So this beta 2 cannot be filtered out by, dialysis. It's going to build up, and once it build up, it can lead to dialysis related amyloidosis. Sometimes it can deposit in here in the wrist as well, giving you carpal tunnel syndrome. Remember? Hello? Hello?
Yes.
What,
Yes.
what
Yes.
about hypothyroidism? We discussed what happens in hypothyroidism. If you remember, mexidemal, glycose, aminoglycans accumulation, right? So glycose,
Mm.
aminoglycan, if you remember, it's going to be having a consistency just like a dove, right? So dove-like consistency. So sometimes it can also deposit here within the wrist, giving you carpal tunnel syndrome. Acromegaly as well. If the hands and the bones are enlarging, it can also give you a carpal tunnel syndrome. Thinning this area, compressing the median nerve. That's your carpal tunnel syndrome. Okay. Okay. So, and we discussed that this lunate dislocation anteriorly can also compress your median nerve, giving you carpal tunnel syndrome. Okay. So we have carpal tunnel. This is the tunnel, right? So, in the end, at the base, basically there they have these bones, and you have flexor retinaculum. In the middle, you have different tendons, and this median nerve, which is really important to know. Okay. Okay, so carpal tunnel syndrome, we discuss entrapment of the median nerve. It can be due to anything. It can be due to amyloidosis. It can be due to glycosaminoglycans. It can be due to acromegaly if the bones are enlarging. So, whatever conditions are impinging this nerve there in your in the tunnel or in your wrist, it's going to give you carpal tunnel syndrome. So we discussed what were the basically the function of your median nerve. If you remember, let me just tell you again. Okay, so for example, if this is your hand. Okay, I just told you that median nerve is going to supply these thenar muscles. What are your thenar muscles? Yes.
Opponens pollicis,
Opponents,
abductor pollicis
poly-
brevis,
abductor, pollicis brevis,
and flexor pollicis brevis.
and flexor, pollicis
Brevis.
brevis. Okay, OAF. That's the mnemonic. Okay. So it's going to supply the thenar muscles. The sensory supply is going to be 1, 2, 3, 3.5. Right? So 3.5 sensory supply given by your median nerve, right? What else? These lateral
Uh,
two lumbricals.
yes, two lumbricals.
Lateral two lumbricals. And the medial two lumbricals are supplied by ulnar nerve, right? The hypothenar muscles are supplied by your ulnar nerve, and all of the interossei muscles are supplied by ulnar nerve, which are responsible for adduction and abduction of your fingers. We discussed that, and along with that, it's going to supply this 1.5 sensory supply, right? Okay, is it clear?
Yes.
Hello.
Yes. Yes.
Okay, that's great. So we have the motor supplies. We know that the thumb movement, the thenar muscles, flexion, extension of the lateral, okay, lumbricals, as we discussed, sensory at the 1.5, 3 or 1.5, okay, 3.5. Okay, carpal tunnel syndrome, as we discussed, it's going to be okay. Bina, okay, it begins with sensory symptoms. Untreated can lead to motor symptoms. Why? Because we know if the median nerve get compromised for a longer period of time, the motor or the nerve, the muscles, for example, the thenar muscles can be affected, right? The hallmark is pain or paresthesia, right? So it's going to be described as numbness or tingling in the distribution of median nerve, which we know what's the distribution of median nerve, right? So it can be due to obesity, we know that. Repetitive hand movement, although that's controversial, right? It can be due to pregnancy. If we have edema, and due to edema, we have compression of the median nerve that can also occur. In diabetes, in hypothyroidism, in rheumatoid arthritis, and inflammatory condition can lead to impingement of median nerve there in the carpal tunnel, which can give you carpal tunnel syndrome, right? Acromegaly itself. So we discussed acromegaly is a lot of hormone, growth hormone release. It can just thicken your bones, and can again lead to impingement of this nerve here, right? Okay. Then we have dialysis related amyloidosis. We discussed beta 2 is component of your MHC1. It cannot be filtered out through your, through dialysis. So it would build in the blood and it's going to deposit in different tissues, including your wrist as well, which can give you carpal tunnel syndrome, right? So there are two signs which we use, physical examination, which we use for carpal tunnel syndrome in order to diagnose or in order to confirm whether we have carpal tunnel syndrome or not. The first one is Tinel sign, the other one is Phelan sign. So what's the Tinel sign? You're going to tell the patient to extend his wrist, right? And then you are going to percuss or tap the thumb, right? If we have tingling sensation in the distribution of median nerve, that's positive Tinel sign, right? So you're going to tap like near your thenar muscles, and if you have numbness or you have tingling here, it's going to confirm that you have problems or you have carpal tunnel syndrome in which the median nerve is compromised. The other one is Phelan sign, which is really simple. You are going to tell the individual to flex his wrist for 60 seconds. And after that flexion, he's going to have tingling, sensation again, right? In the distribution of the median nerve. Okay, just give me a second, please. I'll be back in a minute. Hello. Okay. So the Ferlin maneuver, that's very simple. You're going to tell an individual to flex his wrist for 60 seconds, and he's going to have a tingling situation in the distribution of median nerve, which is going to confirm that he has a individual carpal tunnel syndrome, right? The other thing which you should just keep in mind is you have Guyon canal. So what is Guyon canal? Do you have any idea? Hello? Hello?
Yeah, it's the canal for ulnar nerve.
Perfect. So here you can, that's it's in this picture, you have a canal with the ulnar nerve also runs, right? And it is in close association with which bone? With which carpal
The
bone?
hook of Hammett.
Hammett.
Hook of
That is hook of
Hammett.
Hammett. That's really important, right? So sometimes we can have problems there in the Guyon canal, which can, cause problems of your ulnar nerve, right? So the carpal tunnel is going to cause problems in the median nerve, and in Guyon canal, if you have problems here, it's going to lead to problems of your ulnar nerve. And you know the nervous supply of ulnar nerve, it basically supplies your hypothenar muscles, it supplies the lateral two lumbricals, it supplies all of your interossei. The sensory supply is 1.5, half of your full of your pinky, your little finger, and half of the other one, right? In which we just wear rings or ring finger. Okay, so that's the thing you have to keep in mind. And how does we irritate this ulnar nerve in Guyon canal? Mostly those who are just riding a bicycle. So with the bicycle handle, they can just keep on compromising the ulnar nerve in Guyon canal. And those individuals we are going to be having problems of ulnar nerve mostly, right? So we know the distribution of ulnar nerve. We know that it's going to supply all of the interossei. Anterior interossei are going to cause adduction. Posterior interossei are going to cause abduction, right? Am I right? Hello? It's going to supply all of the
Yes.
hypothenar muscles, the medial two lumbricals, we know that, and the sensory supply to this full and half end, right? So if we have any problems with the ulnar nerve, so this is going to be a factor, right? So overuse of the wrist in the bicyclists, because the pressure on the handlebars can irritate this ulnar nerve, right? Pediatric fractures. Let's discuss some of your pediatric fractures. That's really important, really hygiene. The first one is green stick fracture, right? So for example, if I just take a green stick and I just give it to you and I just tell you to break this stick, can you just break the green stick? No. You can only bend it, right? Hello?
Yes.
Hello? We cannot break a green stick. We can only bend a green stick, right? So the green stick fracture is basically going to be seen in pediatric or children. Why? Because the children do not have hard bones, right? They have flexible bones. just like a green stick, right? Just like a green stick, they have a flexible bond, right? So the fractures does not extend to the width of bond, right? So if you have a fracture, you are only bending it. You cannot break it. You can only bend it. The fracture can occur only in a halfway, right? It would not extend throughout the width of bond. Often occur in distal radius from home. Often it's going to be at the distal radius, right? The bending force applied to the bone, and in which injury? In foot injury, that is fall on outstretched hand. That make a lot of sense in pediatric population. So here you can see it's a green stick fracture, right? So half of it is broken. It do not extend the internal length, and it's going to be bent. It's not broken, right? So it's bent, not broken, which is basically seen in a green stick, right? That's why we have called it as green stick fracture. Was it clear? Hello.
Yes, doctor.
Hello.
Yes,
You
sir.
guys are gonna see an related to this green stick fracture, and I think that's very simple, right? The other one is torus fracture. What do we mean by torus fracture? Again, it's a pediatric fracture, right? So, okay, do you guys know what is diaphysis, epiphysis, and metaphysis? Okay, so diaphysis is this shape, right? This is going to be the diaphysis of the. This is the epiphysis and metaphysis where your both plates are going to be present initially. That's basically your metaphysis, right? So in torus fracture, you have an axial force trauma. What do I mean by axial? The force is going to act in this direction, in the axis. Okay, you can see the force is going to be directed along the axis of your bone, right? So it's an axial trauma. So if as I'm just applying a lot of force in the axial portion, just like that. So what would happen as a result of that? We will be having, you can see this portion of the bone, Okay, let's just give me a second. If I'm just having force on this direction, so you guys can see that this portion of the bone, they have just they get into one another, right? And in this way, you are having a fracture, right? So axial bone, axial, force or axial fracture is going to, it's going to like push the bones in one another. You guys can see here, and you're going to see a fracture here, right? So it's basically due to axial, and this kind of fracture is called as torus fracture. Is it clear? Hello?
Yes, sir.
Okay, perfect. So let's start our next topic, hand. We already know the hand is only a revision, right? Thumb is the first, the second is index, third, fourth, and fifth is the small finger, right? We know the volar is the palmar aspect, and the dorsal is the back of the hand. Laterally, we have thumb, and the little finger is present medially. We know that, right? Am I right?
Yes, sir.
Okay. So let's just different bones. We know that the wrist bones are basically called as carpals. After that, we have metacarpals, we have proximal phalanges, middle and intermediate phalanges, and distal phalanges. Right? We know that. Okay, we know that the nervous supply of ulnar and median nerve. Let's discuss that. If you guys remember, ulnar is going to supply the thenar muscles 1, 2, 3.5 here, right? The other 3.5 supplied by ulnar. Ulnar is also going to supply the hypothenar muscles, lateral to lumbricals, all of the interossei, anterior and posterior, and here. We know that. Okay, let's move forward. Okay, intrinsic muscles. So we have thenar muscles, we have hypothenar muscles, we have interosseous muscle, and we have lumbricals. So we already discussed all of these muscles in detail. Thenar muscles, hypothenar muscles, interossei, and lumbricals. What was the function of thenar muscles? OAF, opposition of your thumb, abduction of your thumb, flexion of your thumb. Am I right?
Yes.
Yes,
Hello?
doctor. Yes,
Okay.
yes.
Here we are going to use polycis. Polycis stands for the thumb, right? Okay, and in the hypothenar, again, we have OAF, but we are going to use digiti minimi, right? Digiti minimi indicates that it's a small finger, the last fifth finger, right? Again, opposition of the small finger, abduction of the small finger, and flexion of small finger, okay? Then we have interossei muscles. So we discussed interossei muscles are present within the bones, interosseous. So we have anterior, or the one on the palmar aspect, and the one on dorsal aspect. anterior interossei muscles are going to cause adduction of your fingers. Okay. And the posterior are going to cause abduction of your fingers. Is it clear? The lumbricals, we know that the lumbricals are going to make L from your hand. That is flexion at metacarpophalangeal joints and extension at interphalangeal joint. We know that. Okay. So let's discuss whether okay. So you can see we have thenar muscles, abductor, pollicis brevis, flexor OAF, thenar eminence, median nerve is going to supply. If you do not have median nerve, you know we are going to be having thenar atrophy. No nerve is supplied, the muscles are going to become atrophic. You know that. Then we have opposition. This is the opposition movement. Okay, then we have hypothenar muscles against OAF, but digiti minimi, small fingers. Ulnar nerve is going to supply that. No ulnar nerve is going to lead to atrophy of your hypothenar muscle. Then we have our interossei muscles. We discussed that. We have the palmar one are used for adduction. The dorsal are used for abduction. Ulnar nerve supply all of your interossei. The lumbricals are making L from your hand. L, right? Flexion at metacarpophalangeal and extension at interphalangeal, right? The medial two are going to be supplied by ulnar and the lateral two lumbricals are supplied by your which nerve? Median nerve. You know that. So flexion and extension, ulnar nerve, lateral two, median nerve. You know that. Okay. Lumbricals, as we discussed. If someone is just falling from a tree, suddenly he just catch any branch of tree and he have damage to the lower trunk, which nerves are going to be gone? Yes, what do you think?
median and ulnar both, because the
If
lower
median
trunk.
and ulnar both are gone, so would the function of lumbricals are gone? The function of lumbricals are not gone. We will be seeing flow hand. Am I right?
Lower hand. Yes.
Flow hand is going to be seen. In that case, no flexion, so extension at metacarpophalangeal and flexion at interphalangeal joint is going to give us flow hand. Am I right?
Yes, doctor.
Hello? Perfect. So these were all of the intrinsic muscle of your hand. What do we mean by intrinsic muscles? The muscles have origin in the hand and insertion in the hand. Both of the origin and insertion, intrinsic muscle of hand occurs within the hand. But what do we mean by extrinsic muscles? Extrinsic muscles origin is up in the forearm, but their insertion is within the hand. Right? That's your extrinsic muscle. Am I right? For
Yes,
the
doctor.
intrinsic muscle.
Sir, can you please
What?
repeat the origin and insertion?
Okay. In the intrinsic muscle, both the origin and insertion of the muscles are present within the hand. And the extrinsic muscle of hand, origin of the muscles are out of hand, that is in your forearm, and insertion within the hand. Am I right? Is it clear?
Yes,
Hello?
sir.
Okay, perfect. So we have an extrinsic muscle called flexor digitorum profundus. Flexor digit, they would lead to the flexion of your digit, right? But since it's an extrinsic muscle, it means that its origin is going to be in the forearm. From the forearm, it would be entering into your hand. You know, that's the definition of extrinsic muscle, and it would lead to flexion of your digits. Am I right? Okay. Remember, your lumbricals basically arises from for example, if this is your hand, fingers, right? Okay. So, and your flexor digitorum profundus have 1, 2, 3, and 4. These are the tendons of your flexor digitorum profundus, right? Okay. The lumbricals arises from the tendons of these flexor digitorum profundus. Am I right? Hello?
Yes, sir.
Hello.
Yes.
So we know that the lateral two lumbricals are supplied by median nerve. if they are arising from the tendons of flexor digitorum profundus, it means these lateral two tendons of the flexor digitorum profundus are also going to be supplied by median. Am I right?
Yes,
Hello?
yes.
And the medial two lumbricals arises from the tendons of your flexor digitorum profundus supplied by ulnar nerve. It means that the tendon of medial two tendons of your flexor digitorum profundus are also going to be supplied by your ulnar. Is it clear? Hello. Is it
It is.
clear?
Yes, sir.
Yes,
Yes,
it
sir.
is blue. Yes.
Perfect. So you can see here the extrinsic hand muscles. We have extensors. Okay, extrinsic hand muscle, right? Extensor. We discuss about the flexors. Let's discuss about the extensor, right? So at the back of forearm, and what will be the function of these extensors? They are going to extend the digit. Okay, so we have extensor digitorum. Okay, so extensor digitorum, they are going to cause extension of your digits, finger, and all of the extensors are being supplied by the radial nerve. We know that. Okay, so it strongly extend the metacarpophalangeal joint, which is opposite of the lumbricals, right? Lumbricals were basically causing flexion here. They're going to cause, extension at that. Okay. So let's discuss risk deviation. That's really important. Okay, then really simple as well, right? Remember we discussed, for example, if this is okay, let me just draw your humerus and your ulna. This is your ulna and this is your radius, right? And this is, let's suppose, your thumb and your fingers. Okay, let me just draw an extra thing. Okay. So let's suppose we discuss this our medial epicondyle and our lateral epicondyle. We discussed from the medial epicondyle, all of the flexors are going to arise. Do you guys remember it?
Yes, doctor.
Okay, and from the lateral epicondyle, all of your extensors are going to arise. Remember it? Extensors are going to arise here. Most of these muscles at here at the ulnar side are going to be supplied by the ulnar nerve. Most, not all, okay. And at the lateral side are going to be supplied by which nerve? By your radial nerve, because they are extensors, right? Hello.
Yes, doctor.
Hello.
Yes.
Yes,
Yes.
doctor. Yes, sir.
So remember, whenever we have any problem with the ulnar nerve here, it means that the opposite group muscles are going to be dominated. Am I right?
Yeah.
If I just cut the ulnar nerve here, it means that the opposite group of muscles would dominate. So whenever we have problems with ulnar nerve, can I say we will be having radial deviation of the wrist?
Yes. Radial.
Okay. If we have
Yes.
problems with the radial nerve, I would say that we are going to be having ulnar deviation of the wrist.
That is correct.
That which is wrist deviation, right? So median nerve lesions, we know that we have discussed it again and again. Loss of the thenar muscles, loss of the lateral two lumbricals, and sensi 3.5, right? So median nerve injury, you are going to be having median or claw lateral digits. We know that. So let's discuss it here. Next slide. Okay. So you can see, if we have problem with the median nerve, it means that we cannot flex at this joint. Am I right? The loss of lumbricals, loss of your median nerve. Can we flex at this joint?
No.
Hello. Okay,
No.
so it means that this joint is always going to be extended. Am I right?
Yes.
Yes, doctor.
And
Hello.
Yeah.
Yes.
Can we abduct the thumb? Can we abduct the thumb? No.
No.
So it means it's also going to be always adducted. Am I right?
Yes.
Hello.
yes.
Can we extend at interphalangeal joints? No. So they would be flexed, right? Because the lumbricals are lost, the function of lumbricals are lost. It means we can't be having proper extension, so they would be flexed. So if you are telling this individual to make a fist, right? So he cannot flex here, he cannot cause abduction, he can only, although the ulnar nerve is fine, so we will just make a sign which is known as Pope's blessing or hand of Benedict. Is it clear?
Yes, sir.
Yes.
Individual with median nerve lesion, whenever we just tell him to make a fist, he's going to make a sign of benediction or hand of benediction. That's a Bob's plus, right? But if you're just telling this individual to keep your hand normal, it's going to give you ape hand. You can see ape's hand. Why? Because here you have thenar atrophy, right? You have a flared hand here, right? And here you can see lumbricals function are gone. So we have flexion here and extension here. And abduction of your thumb, because median is gone, no abduction. So it's an ape hand at rest. Is it clear? Whenever with median nerve injury, if you are just telling an individual to make a fist, he's going to give you a Bob's blessing. You are just telling this individual to be at rest, it's going to be an ape's hand, just like an ape's hand. Okay, is it clear?
So, what's happening there is extension at metacarpophalangeal joints and flexion at proximal and distal differential joints.
Yes. Thenar atrophy and adduction of the thumb, because abduction or F was the function of your median nerve. How can median nerve get injured? If you guys remember, we discussed one thing. Some fracture discussed before. What was that?
Bone.
Supracondylar fracture. Remember the supracondylar fracture? Supracondylar fracture is going to cause damage of which nerve?
Median nerve.
Yes.
Median nerve and radial artery.
Median nerve. Perfect. So whenever you have supracondylar fracture, median nerve is going to be gone. If you have carpal tunnel syndrome, if we discuss, median nerve is going to be gone. Right? So we have a branch of median nerve which we'll be discussing in a bit. It can also be affected if you have superficial injury to the wrist. So let me just discuss in that. Okay. So the median nerve is gone. Okay, so no wrist deviation is going to be seen. Wrist deviation is going to be seen in two cases, either the ulnar or the radial is going, which we discussed, right? Median nerve lesion, if we have supracondylar fracture above the condyle, we have that median nerve passing here, right? So if we have fracture of, it's one of your dual MCQ as well, they're going to ask you this. So if we have supracondylar fracture, it's going to lead to median. Okay, can you guys just tell me Dr. Hasnain is in which module now?
Just finished cardiovascular.
We just finished cardiovascular. So what's his plan
Probably.
next?
Most probably we will be starting musculoskeletal or hematology.
MSK. Okay, okay. So just request him that once you're doing anatomy, just tell him to do anatomy of the neuro as well. Okay, because all of the anatomy of neuro is your MSK. Okay. Only have 47 MCQs in your viewer in the MSK, and we have like around about 108 MCQs of the same anatomy in your neuro, right? Just tell him to start the neuro anatomy directly. Okay. So 95% to 98% are the MCQs are from your MSK. Okay. So, okay. So ulnar deviation. Okay. Recurrent branch. As I already told you that we have one branch of the median nerve called as recurrent branch, right? It basically runs superficially, and this branch supply all of your, thenar muscles except your sensory supply. Really important, right? So it's a motor innervation to the thenar muscles, one of the branch of your median nerve called recurrent branch. It supplies the motor innervation to thenar muscles, and it do not have any sensory innervation, right? And it runs superficial to your flexor retina. So whenever we have any kind of superficial palm injury or cut, it can lead to damage of recurrent branch. It can lead to problems with the nervous with the muscle supply due to this nerve, and we won't be having any problem, any sensory problem, that is 3.5 sensory innervation disrupted, because we know that the 3.5 is supplied by the median nerve. So it's really important to remember this branch of median nerve as well, right? So immobilize the thumb, and the sensation is normal because you do not have any sensory supply. The ulnar nerve lesion we discussed in detail. Let's just revise it. laws of AB reduction and AD reduction. Why? Because the function of your interossei are gone. Anterior or palmar interossei lead to AD reduction. Posterior interossei lead to AB reduction. Motor laws at 1.5 finger, little finger, and half of the ring finger, hypothenar muscles. You know that. Claw hand, ulnar claw. What is ulnar claw? We know that if the ulnar claw, ulnar nerve is gone, the lateral two lumbricals are gone. If the lateral two lumbricals are gone, we cannot flex at this joint and we cannot extend at this joint. Right? So if you just tell this individual to just place his hand on the table, he's going to be having no, just like that. Okay. That's basically your ulnar claw. Am I right?
Yes, you are.
Okay, so this is your ulnar claw. You can see that here we have extension at the metacarpophalangeal and we have flexion at interphalanges. So it's going to give us ulnar claw, right? Okay. So you can see that ulnar nerve, we discussed that it basically runs at the medial epicondyle. It can be, either we can have laceration, Guinan canal also have the other that ulnar nerve is going to lead to, innervation to all of your hypothenar muscles. If we have problems with ulnar nerve, we're going to be having radial wrist deviation, which we discussed. Ulnar paradox. What is ulnar paradox? Remember, whenever we have proximal lesion, okay, so we have two types of lesion of the ulnar. Like either the ulnar nerve can be lesioned at the medial epicondyle, or either it can be lesioned distally at the level of your wrist, and either Guinan canal or either near the retinaculum side. Okay, so whenever we have proximal lesion, the ulnar claw may not be seen. Why? Just keep one thing in mind. Okay, let me just draw the picture again. I just told you that, okay, for example, if this is your, okay, 1, 2, 3, 4, and thumb. Okay, for example, if this is your, I just told you that these medial two lumbricals are going to be supplied by your ulnar nerve. Remember? Hello? Hello? I just told you that they arise from the tendon of your flexor digitorum profundus, right? And the tendon of the flexor digitorum is also supplied by your ulnar nerve, these lateral, the medial two. Remember?
Yes, doctor.
Yes.
Hello? Okay. So whenever we have lesion of this ulnar nerve proximally at the level of elbow at the medial epicondyle, so function of the lumbricals won't be gone, right? Because whenever the lumbricals are gone, we have ulnar claw, right? Okay, so most probably, the flexor component or the flexor digitorum profundus, that's going to be, dominated, because the ulnar, you won't be having ulnar claw, right? The ulnar claw was mainly due to the loss of function of your lumbricals. Am I right? Hello? Hello? Okay.
Yes, doctor.
We'll be having flexion at the interphalangeal joints. Okay, the flexion at interphalangeal joints may not be seen, right? But if we have lesion at the proximal level of ulnar nerve, right, somewhere at the Guinan canal, in that case, the lumbricals are going to be dominated. That's going to lead to ulnar claw. This point is not really important, but still you have to know it. Whenever we have proximal lesion of the ulnar, no ulnar claw is going to be seen. Whenever we have distal lesion at ulnar nerve, then we are going to have that ulnar claw. Is it clear? Hello?
Yes, doctor.
Okay. So with this, we have finished all of our upper limb, right? And now tomorrow we are going to start at lower limb, and we are going to be having a little long session, okay, to complete this entire lower limb. After that, we'll be starting our physiology and pathology, right? So this week we are going to finish our MSK and just get ready for the neuro, right? So most of the students feel a lot of difficulty in the neuro. The neuro, as I already mentioned, that we are going to do it from multiple resources, right? From Dr. Najib notes, okay. Apart from that, we're going to do, the entire first aid. Along with that, we're also going to practice my own notes. I have just written some notes, and along with that, I'll also be discussing some of keyword and MCQs with you guys. Okay. right? So along with the topics, we are going to integrate some word MCQs just with the topics. Okay. So thank you so much. Hope so you guys enjoyed the session today. Thank you so much, and see you tomorrow. Bye bye.
Thank you so much, Doctor.
Thank you.
Thank you so much. Thank you, Dr. Ahmed. Question, do you have like a PDF for Dr. Najib notes?
Yes, I have a PDF. I'll be sending that, right? But before the session, not now.
Okay, thank you.
Okay. Thank you so much. Thank you.
You're welcome. Bye.